of our enlightening webinar series on genetics and embryology. It's wonderful to see you all here again as we continue to expand our knowledge in these fascinating fields. Today, we are honored to have with us Dr. Rajsree, a renowned expert in the field who will deliver an in-depth session on the crucial topic of newborn screening. Dr. Rajsree Sreedevi, a neonatologist with more than 15 years' experience in neonatal intensive care, is presently working as a consultant neonatologist at Aster Medcity, Kochi. She is an alumnus of Government TD Medical College, Alapura and Government Medical College, Thiruvananthapuram. She did her neonatal fellowship from Amrita Institute, Kochi. After her post-graduation, she has been working in NICUs of KKCTH Chennai, Surya Hospital, Vadapalani, SUT Hospital, Thiruvananthapuram, Amrita Institute of Medical Science, Kochi, and till date at Aster, Kochi. Her special areas of interest are optimal care of extreme premature babies, neonatal pulmonary physiology, and ventilator care. She is also a mentor of neonatal care in the National Quality Care Network of India. We welcome you, ma'am. This promises to be an engaging and informative session, so I encourage you all to stay tuned, take notes, and actively participate during the Q&A segment. Without further ado, let's welcome Dr. Rajsree to share her insights and expertise. Over to you, ma'am.
Ma'am, are you there? We can see the screen, but it's not audible, I think.
Rajsree, ma'am. Ma'am, you're not audible yet. Ma'am, you're not audible yet.
Is it audible now?
Yes, ma'am. Now you're audible.
Okay. There is some problem with the adjustment.
Are you able to share the screen now, ma'am?
Yeah. Is it visible now?
Sure. Yes, ma'am.
Shall I start?
Could you put? Yes, ma'am. You can start with putting it on the slideshow.
Okay, just a moment. Hi. Hi all. I hope I'm audible now.
Yes, ma'am. You're audible.
So this is a very vast topic, neonatal screening for genetic and metabolic disorders. So as you all know, there are numerous genetic conditions and numerous metabolic conditions. My plan for today will be an overview of the genetic and metabolic conditions and how to spot a baby when a baby arrives in NICU or when you encounter a neonate, how to spot that whether the baby is having a genetic or a metabolic condition. And if you decide that this baby, yes, this baby is likely to be a genetic condition or this baby is likely to have a metabolic condition, then how to approach it? How will you approach the baby? How will you evaluate the baby? So, all those things and how to go about the diagnosis and the management, the treatment part, just I will mention the treatment part, and the main genetic conditions and the metabolic conditions I'll be covering. So, that is the plan for today. So, initially, we'll go to the definitions. Considering the genetic conditions, what are the main definitions should know about? One is birth defect. So, what is birth defect? It is simple. A defect which is present when the baby is born. That's all. What is a malformation? A malformation means there is abnormal development. From the development of the organ onwards, there is some abnormality. So, an abnormal development leads to a
Excuse me,
malformation.
ma'am.
Sorry?
Sorry to interrupt.
Yeah.
Ma'am, are the slides changing for you?
You're not able to see the next slide?
No, ma'am. We're only able to see the first slide, and I think it's not in slideshow either.
Okay, just a moment.
Yeah, now it's visible, ma'am. Definition slide is visible.
Okay. Is the slide visible?
Yes, ma'am. Now it's better.
Okay. So what is a deformation? Deformation is because of the organ is normally developing, but then the mechanical change has happened. So it has become deformed. So why it has become deformed? Because of some metabolic, mechanical deformation, mechanical change which happened. So this can be due to oligohydramnios. When the baby is in the uterus and there is oligohydramnios, there is compression of the limbs or organelles, and what happens is the limb is sometimes deformed, like clubfoot. So this is called a deformation. What is a disruption? Disruption is some interruption in the normal development of a part. So this happens mostly in amniotic band syndrome. That is a typical example for a disruption. So when there is amniotic band, it encircles a limb and the rest of the limb may be disrupted from forming completely. There is interruption in the development of the limb, and the distal part of the limb may not be formed at all. So that is called disruption. Now, what is a sequence? Sequence means a single abnormality causes multiple defects. So what is a typical example of that condition? Can any of you talk about a sequence? One condition leading to another. So the typical example is Peary-Robin syndrome. Anybody, what is Peary-Robin syndrome? Am I audible? Am I audible?
Yes,
Yeah,
ma'am, you're
ma'am.
audible.
Yeah. So what is Peary-Robin syndrome? Peary-Robin syndrome means there is,
Small sized mandible retrognathia.
yes, very good, very good. So there is a small size mandible. There is retrognathia. So retrognathia causes what? The tongue is behind. Because of the small mandible and the retrognathia, the tongue is behind because tongue arises from the floor of the mouth and it is behind. There is falling back of the tongue. So because the tongue is falling back repeatedly, what happens? It falls on the palate and the palate is not developed at all. So there is a cleft palate also. That is why in Peary-Robin, the palatal cleft is typically posterior and a U-shaped palate. It has the typical shape of the tongue. Because the tongue is falling back onto the palate, there is a cleft, palatal cleft, which is posterior and which is U-shaped. So that is, and because of the tongue falling back, there will be other problems like baby has feeding problems. In our NICU, just now there is a Peary-Robin syndrome, which we are finding it very difficult to feed the baby because usually in cleft palate, if it is a large cleft palate, what we do is there is an obturator to block the cleft palate, and then we'll try to feed the baby with a long nipple bottle. But here the problem is the baby, because of the tongue falling back in the supine position. In the supine position, the tongue is falling back and it is blocking the airway. So baby cannot be in supine position for a feed at all. So we have to feed the baby in the prone position. On tummy position, you have to feed the baby, and in that position, it is very difficult to feed with the long nipple. So what what we're trying to do for that baby is we have inserted a nasopharyngeal airway, an airway through the nose, so that there is some airway for the baby. When a nasopharyngeal airway is inserted, there is some airway, there is some way for the air to go into the baby, and so the baby can be in supine position now. After the nasopharyngeal airway insertion, baby can be in supine position, and after that, we are trying to feed with the long nipple bottle. So now the baby is able to take the feed with a lot of other, collaborations around that. Somebody has to be ready with the suction and all that. So we are teaching the mother now. Probably they'll be ready to go home within a week. So that is called a sequence. When retrognathia, falling back of the tongue, leading to maldevelopment of the palate, and there is a palatal cleft which is posterior and U-shaped. So that is called a sequence. Now, what is a syndrome? Syndrome means a bunch of abnormalities which are developmentally related. That is Down syndrome. Typical example where the trisomy 21 is causing all the abnormalities associated with that syndrome. That chromosomal error is causing all the abnormalities in Down syndrome. Now, what is an association? Typical example of an association is Vater. The vertebral defects, the anal problems, the tracheoesophageal fistula, the renal abnormalities, the limb defects, everything is an association. It is a non-random, it is not a random clustering, it is a non-random clustering of various abnormalities which always happens together. So that is called an association. I hope the definitions are clear. Now we'll go into the next part of the leg. how to, when a baby comes, typically when a baby is delivered and you spot something which is not right with the baby, you look at the face of the baby or you look at the limbs of the baby, the normal head to foot examination which happens for all the babies when the baby is born, you find something which is amiss with the baby, maybe a dysmorphic face, maybe polydactyly, or some abnormality with the limbs, uh, or then you think about whether it is a genetic defect. So then you go back into the history. Of course, the main antenatal history will be mentioned before that, but you go back and think about whether there is any other relevant history connected with this, because the baby has some dysmorphism or a defect. So the main thing is parental age. Parental age is very important because, as you know, maternal age or paternal age. Maternal age is more important because, just a moment. So maternal age is connected with which syndrome? More than 35, maternal age more than 35 is a risk factor for,
Down
Down,
syndrome.
Down
Down,
syndrome.
sorry,
Down syndrome.
Down syndrome. Yes. So more than 35 is a risk factor for Down syndrome. Paternal age more, if the paternal age is more, it is connected with, it is said to have a connection with achondroplasia. So parental age is very important. Then antenatal exposure to any teratogens. So which are the teratogens? Numerous toxins which can act as teratogens, like heavy metals, then some of our chemotherapy drugs, lot of other drugs can be teratogens. So antenatal exposure to any teratogens, radiation can be a teratogen. If the mother is treated with radioiodine, then that can be teratogen. So numerous other factors are there. And of course, the history of, when you go into the history, there is a previous death in the family, previous neonatal death in the family, or history of many people undergoing infertility treatment, mothers, maternal siblings or paternal siblings, numerous people in the same family undergoing infertility treatment, or a previous abortions, previous pregnancy loss for the mother or her sisters, is very important. Then the other important thing is family history of similar congenital malformations, family history of mental retardation or neurological abnormalities, then consanguinity, especially second degree consanguinity, is very important in autosomal recessive disorders. Then the liker abnormalities like oligo or polyhydramnios. Oligohydramnios is mostly associated with conditions like renal, associated with renal malformations where the urine cannot be formed at all. So those conditions will be associated with oligo, whereas polyhydramnios is usually associated with conditions where the fetus is having difficulty swallowing. So difficulty swallowing, it can be due to a neuromuscular disorder where baby cannot swallow, the fetus cannot swallow, and hence there is polyhydramnios. And abnormal presentation is also usually seen in neuromuscular disorders, where baby is not able to turn around. It will be usually breech presentation or a transverse lie because the baby cannot move much. So neuromuscular disorders are typically connected with abnormal presentation. And the next is reduced fetal movements. Reduced fetal movements again is seen in neuromuscular disorders like congenital muscular dystrophy, where the fetal movements will be very less. And can you tell me a condition where there is increased fetal movements? PGs are there? Any of you? Increased fetal movements can be seen in which condition? It is just a logical answer. It can be seen when baby is having, fetus is having seizures. If fetus has seizures in utero, the mother perceives it as increased fetal movements. So these things in the history we should go back when the baby is we find the baby to be abnormal in any sense. It is better to look at these points in the history, especially, and also uh, usually nowadays we'll be notified previously itself in the antenatal ultrasound. They pick up a lot of things. Sometimes they are normal, abnormal. Lot of things they pick up, slightly abnormal things also. So lot of findings will be there in antenatal ultrasound, which are sometimes foramen magnum, which is prominent. All these conditions can be it is normal in any baby, it is not connected with any abnormality in the general abnormality in the baby. But even then, all these findings are picked up. So usually, abnormality detected by the antenatal ultrasound will be the first alerting factor for any neonatologist. They'll be informing us this baby comes with this, so please take care. So we'll be having that in mind when the baby is received. Then any maternal illness like diabetes mellitus in the mother, or hypertension in the mother, thyroid disorders in the mother, all these conditions, SLE in the mother. Uh, what is the uh, what is the abnormality in the baby when the mother is having SLE? Mother is having SLE and certain antibodies are positive for the mother. Uh, Typically, the baby will be having sometimes bradycardia, cardiac conduction block in the baby. So these mothers, when mother is presenting with SLE, mother has SLE, on treatment for that, anti-Rho, anti-La antibodies are positive in the mother. Then we admit the mother into the NICU for at least 24 hours and monitor the heart rate of the baby. Sometimes they can have conduction defects, heart blocks, and sometimes they have to be treated with medicines for that. And smoking and alcohol ingestion in the mother. Nowadays it is increasing. So these things are also associated with congenital abnormalities in the baby. Now, examination, as I told you, any baby who comes, there'll be a head to foot examination. So, in head to foot examination, very detailed head to foot examination is needed for each baby. And especially when you are finding an abnormality in the baby, the head circumference should be measured. Then the fontanelles should be palpated. See whether the fontanelle size is more than usual or there are fused sutures already. Both are abnormal. Then look at the ears, see whether they are low set. Low set ears are associated with many genetic conditions. Then see whether the eyes are widely spaced or eyes are close together. Both are abnormal. Eyes close together can be associated with Patau syndrome, trisomy 13, and eyes widely spaced eyes are seen in a variety of genetic conditions. Then the shape of the nose, flat nose. Um, look into the mouth and see whether there is a palatal cleft. Sometimes that is the abnormality which is mostly missed, because we should open the mouth and palpate the mouth also. Sometimes open the mouth and see there may not be a visible cleft in the palate, but sometimes when you palpate, you can see a submucosal cleft in the palate. Then look at the neck, folds in the neck, skin folds, extra skin folds in the neck, whether they are there. So extra skin folds are associated with a variety of conditions like Down syndrome, it can be there, Turner syndrome, it can be there. So these things, and then we come to the body. Also the back of the head, occiput, the shape of the occiput, flattened occiput can be there, prominent occiput can be there. So all these conditions, all these shapes of the face itself can tell you a lot of, and there are criteria for this, like uh, the shape of the mouth, or the widely spaced eyes. There are criteria, there are measurements for this. Low CTS, there is a measurement for that. So you have to measure all this using a tape and identify or spot whether it is really low CTS or not. Then after that, you go to the nipples, widely spaced nipples, typically Turner syndrome. Then look at the hands, the feet, fingers and toes can tell you a lot of stories. sometimes post-axial or pre-axial polydactyly can be there, which are typically associated with certain conditions. Then a detailed systemic examination of the baby is also important. Uh, Examine for the heart rate, the heart sounds, the murmurs, all that, and neurological examination, the tone of the baby, the spontaneous movements in the baby, all that is comes in the initial examination itself. Then the abdominal palpation for the baby, see whether the kidneys are palpable. Normally, kidneys will be palpable in a baby. See whether they are palpable. See whether the liver is huge or the spleen is there. All these things in the abdomen. If whether there is abdominal distension, whether there is scaphoid shaped abdomen, that is abdomen which is going in, because sometimes in diaphragmatic hernia you find the abdomen going in because the bowel loops are not there. Bowel loops are in the chest and the abdomen will be flat. So all these findings in the tummy, and always turn the baby towards the, in prone position, and examine the spine as well, because that spinal examination is very important. In spine, spinal anomalies like meningomyelocele can be associated with lot of uh, genetic conditions, like Meckel-Gruber syndrome, which has an encephalocele. So the around the cervical region, around the neck region, you can see the occipital encephalocele in that syndrome. So spinal examination is very important, and the limbs, as I told you, the shape of the limbs. Then, of course, the most important thing other than that is the genitalia. The ambiguous genitalia, sometimes, hypospadias, abnormalities, or imperforate anus. Imperforate anus is associated with Down syndrome. So these conditions uh, have a detailed examination in the baby and a detailed systemic examination. All these are the major base for our diagnosis. And after the detailed examination, list out the positive findings. What are the positive findings? If the baby is having
नाही
many,
तोंडाबद्दल पण फुल नको घालशील. वरण पण कालचं खूप झालं होतं बरं. वरण आहे वाटतं ना आमची, एका ह्याच्यात असेल ना घट्ट. हा, खूप नको घालू. 2-3 वाट्या होईल एवढंच.
Dr. Spurti, kindly mute yourself.
so because after the head to foot examination and the systemic examination, you list out the positive findings. And if there are numerous positive alerts in the examination, then you should go for a bedside ultrasound and an echocardiography for the baby. So ultrasound, you can do the abdomen and the cranium at a go, and see whether any major abnormalities are there in the brain or in the abdomen, because most of the genetic conditions are associated with either abnormalities in the kidneys or abnormalities in the brain. So see whether, because these things can tell us a lot of things, and these things can help us to clinch the diagnosis. So see whether any positive findings are there, and of course the echocardiography, because cardiac abnormalities are associated with lot of syndromes. So the echocardiography is also very important. See the echocardiography and see the structure of the heart. See whether any abnormalities are associated with that. Typically in Down syndrome, you get which defect in the heart? In Down syndrome, endocardial cushion defects are very common. AVSD, atrioventricular septal defect, is very common in Down syndrome, and they can be associated with pulmonary hypertension as well. And in Turner, which is the very common abnormality seen in Turner syndrome, cardiac abnormality seen in Turner is coarctation of aorta. So there are some typical cardiac findings which are associated with some syndromes typically. So these things can also give a clue to the diagnosis. So after all this, that head to foot examination, a detailed systemic examination, and a bedside USG and echocardiography, you get all the positive findings, and then you have to do a, depending on that you can, because otherwise a chromosomal analysis is very misleading. So once you have all the positive findings, then you go and compare with either standard textbooks like the Smith's textbook on genetics, on the syndromes. All the syndromes are seen in Smith. So if you take Smith and go into they have an index also. So from that index you can see the all these cluster of findings can be seen in which syndrome, and from that you can pick up the syndrome, and that specific genetic abnormality can be easily detected. Nowadays the database, like you can compare with the database, OMIM database is there. So all that the positive findings can be compared with that also, and you can easily come to the diagnosis. Now after the diagnosis, karyotyping, whether our impression is correct, that we can conclusively say after karyotyping. So karyotyping, then of course, if the baby is a small baby and there are abnormalities like this, torch screen also is very important, because congenital infections like toxoplasma, the cytomegalovirus, herpes virus, all these can cause abnormal development of the babies. So sometimes babies look like they are they'll be sometimes small for gestational age. They have numerous other abnormalities, varicella infection in pregnancies associated with the skin scars in the baby, and sometimes limb defects in the baby. Microcephaly in the baby is seen in lot of such conditions. So torch screen is also very important when the baby seems to have a lot of birth defects. And skeletal survey is another important. So take an X-ray, take an infantogram, which is like head to foot X-ray of the baby. This will also tell us a lot of things, whether there is an absent bone. Sometimes radius will be absent. So that is seen in absent radius is seen in numerous syndromes like Fanconi syndrome, it can be there. So see the skeletal survey. Then if you have found any abnormalities, sometimes you may not find all the abnormalities in the USG cranium. Ultrasound cranium may not tell you everything. So then MRI brain is the investigation for that. If there are bony abnormalities, CT is the preferred investigation for that. Now, X-ray skull is also important, because that can also tell you in like torch infection, cytomegalovirus, there can be calcifications. Toxoplasma, there can be calcifications inside the brain, which can be picked up by the X-ray skull. So these things. Then, if the baby seems to have, dysmorphism, and the baby's behavior looks like, baby is not very active, all these things are there, then you can do a metabolic workup also for the baby, because numerous metabolic conditions are associated with, sometimes at birth itself they'll have like respiratory chain disorders, mitochondrial disorders. They will have the abnormality, the baby presents at birth itself. Even before starting the feeds itself, they will be have an abnormal behavior, like the activity will be very low for the baby. So then you can, the baby can undergo metabolic workup as well. Now, the management for any genetic and metabolic condition, the most important thing is contact the geneticist. The geneticist should be consulted in such cases, and when we are counseling the parents, geneticist also should be there, and all the physicians who are taking care of the baby should counsel the parents. Then, if the parents, like some conditions, they then for the next pregnancy it is very important. So prenatal diagnosis for the next pregnancy should be advised. Sometimes screening for both parents, sometimes chromosomal anomaly is there in the baby. Screening chromosomes of both parents is very important in such conditions. And if the index case, that is, if this baby has a very poor prognosis, and in case this baby doesn't survive, then we should also advise autopsy for that baby, because that is also very important. That can also lead to various findings, especially if the karyotyping and the chromosomal analysis was not possible for the baby, because the baby was very sick at birth itself, then autopsy can. Now, the prenatal diagnosis, what is the main thing is antenatal ultrasound. As we know, 3 antenatal scans are done for all the pregnancies now. So these 3 antenatal scans, especially the anomaly scan, which is done at around 92 weeks of pregnancy, will tell us a lot of positive findings. But 19 to 22 weeks is little late because the baby will be almost getting viable at that point of time. So because of that, the early scan, which picks up the nuchal translucency at around 9 to 10 weeks, that is also the very important thing. So after 6 weeks scan, when the pregnancy is detected, it is better when the risk factors are there, the mother should undergo scan at around 10 weeks, 9 to 10 weeks of pregnancy to pick up the nuchal translucency, especially when maternal age is more. Maternal serum test, that is a triple test, alpha-fetoprotein, estradiol, and HCG. So alpha-fetoprotein and estradiol are decreased in Down syndrome-like conditions, while AFP is increased in neural tube defects. So some conditions it is increased, some conditions it is decreased. HCG is elevated in trisomy 21. So this triple test is very important. Then chorionic villus sampling, that is, we can take the sample from the chorionic villus and have a DNA test for the baby. The chromosomal test can be done for the baby, but it should be done at around 11 weeks of life. And it can be done transcervically or transabdominally, but there is a fetal loss risk, which is around 2 to 3%. Because it is early in pregnancy, the fetal loss risk is more for chorionic villus sampling, while amniocentesis is done at around 16 weeks, and the fetal loss risk is low, only 1% for amniocentesis. But the problem is by 16 weeks, if you do the test and you get the test result within around 2 or 3 weeks, baby is already around 20 weeks, and it will take time for the parents to be counseled and to arrive at a decision by the time the baby may be viable also. So that is the problem with amniocentesis. Now, can you all look at the picture? Because we have been talking for a long while. I have been talking for a long while. Can you look at the picture and tell me what are these findings and what is the syndrome?
Down syndrome.
Yes.
Down syndrome.
So this is yes, good. This is a very common presentation. That is the single palm arc crease is there. Clinodactyly is there in the first finger. Hypotonia for the baby. Hypotonia improves to a certain extent, but it will be there. Then the upslanted palpebral fissures, which is very typical for Down syndrome. Flat nasal bridge. The occiput will be flat for a Down syndrome baby, and the nuchal folds will be there. Then baby can have the chest abnormalities can be there. Sometimes these babies can have internal abnormalities like duodenal atresia. Various other problems can be there for Down syndrome baby. So Down syndrome is typically, we know it is trisomy 21. So why the trisomy happens? The trisomy can be due to mitotic non-disjunction or a translocation. So this is very important. When you do a chromosomal analysis, we should determine whether this is non-disjunction trisomy or a translocation trisomy. Because translocation trisomy, it can be higher risk for the next baby as well. If it is a translocation trisomy, the parents should undergo chromosomal analysis. So in Down syndrome, it is very easy to spot the baby because the facial features are there, the semen crease is there, the sandal gap is there, the hypotonia is there. And in any Down syndrome baby, we should be examining the baby whether there is any, mostly duodenal atresia. Duodenal atresia is a very common condition associated with Down syndrome. Sometimes babies referred for duodenal atresia alone, because in newborn we know the facial features are not very well formed. So in a newborn baby, baby comes with baby is born and baby is been vomiting. Bilious vomiting is there, so they have referred the baby. They take the X-ray because bilious vomiting is there. Then they see only 2 bubbles in the tummy. The stomach bubble is there, and the first part of duodenum is there. So they suspect duodenal atresia and they refer the baby. When the baby comes with duodenal atresia, we should always have a suspicion of Down syndrome. It is that common. In Down syndrome, duodenal atresia is that common. So it is associated with duodenal atresia. Imperforate anus is also seen. Hirschsprung's disease is seen. Hirschsprung's disease may sometimes present very much later. It depends on how much segment of the colon is affected. Sometimes if a very small part of colon is affected, baby may not present at all. There will be only constipation for the baby. Uh, and that will be taken as a normal type of thing. And so if there is a long segment Hirschsprung's, then it presents in the newborn period itself. Deaf also can be tracheoesophageal fistula can be seen in Down syndrome. Bile duct atresia can also be seen in Down syndrome. 50% of Down syndrome kids will have congenital heart disease. So all these babies should undergo an echo. And the commonest characteristic defect which is seen is, as I told you before, AVSD, atrioventricular septal defect. So in AVSD, in Down syndrome, it is better for the kids to undergo an early surgery, because even if they undergo an early surgery, sometimes they can develop pulmonary artery hypertension. Even if that AVSD is not there, they are prone to develop pulmonary artery hypertension because they have abnormality in the pulmonary vessels development. Then thyroid monitoring is needed at specific intervals for the baby. Even if the newborn thyroid values are normal, the T4 TSH we do as part of newborn screening is normal for the baby, even then baby should undergo repeated thyroid testing at specific intervals, because hypothyroidism is very common and it can develop at any age for a Down syndrome baby. And we know that Down syndrome, it is associated with a variable degree of mental retardation. And since thyroid also can lead to mental retardation, in any Down syndrome baby, we should try to prevent that insult, that further insult to the baby's IQ capabilities. Then chromosomal analysis, as I told you, it can be non-disjunction or it can be translocation. So if it is translocation, we have to screen the parents also, because the recurrence risk is high for translocation, especially if it is a 21-21 translocation, it is 100% recurrence risk is there. And if the mother is a translocation carrier, the risk is 10%. If the father is the carrier, it is only 2%. That is because the sperms, the defective sperms, usually have a reduced capacity to fertilize the ovum. So because of that, if the father is a translocation carrier, the risk is very low, only 2%. Yeah, and maternal age also. That is, if the mother is less than 40, only 1% risk. Higher maternal age increases the risk. Now, this is another. Can anybody pick up the diagnosis from this? You can see the baby with facial abnormalities not very evident in this. The neck folds are seen, or rather, it is a webbing of the neck. Webs can be seen.
Turner syndrome.
Yes, very good. So the lymphedema is also there in the feet. So Turner syndrome, typical findings are the webbing of the neck, the lymphedema. So in any short female, sometimes, in the neonatal period, of course, lymphedema is the very typical finding which is seen. But even in later age, when a short female comes, we should have a suspicion of Turner syndrome. If the short female with normal intellectual capabilities and a carrying angle, a wide carrying angle, and some abnormal features, then we should have an eye for Turner syndrome. So, short female, lymphedema, widely spaced nipples, cubitus valgus, which is the wide carrying angle, poor development of secondary sexual characteristics later on, and there is no mental retardation at all. And the chromosomal analysis yields X0. The cardiac evaluation should be done because it is typically associated with either coarctation of aorta or sometimes bicuspid aortic valve. Just a bicuspid aortic valve can also be there in Turner syndrome. Then USG abdomen should be done because streak ovaries can be there and horseshoe kidneys can be there in Turner syndrome. And these kids, we can help them to attain the secondary sexual characteristics and some emotional satisfaction for them in by doing cyclical estrogen progesterone treatment and growth hormone can also help, but the dose will be very high and the treatment will be very expensive. Growth hormone can help in increasing the height to a certain degree. The words are not very clear in it. Is what is this one? There is a very prominent occiput. Then
Edward.
Edward, yes, very good. So this is trisomy 18. Typically, the overlapping digits are there. The malformed ears, which malformed ears can be seen in numerous other syndromes also. The rocker bottom feet is not visible in this picture, but the rocker bottom feet is also an important feature of Edward syndrome. So small mouth, it will be a typically SGA baby, very small baby. Term baby with a weight of around 1.8 kg will be the typical presentation of Edward syndrome, with small mouth, small jaw, short neck, shield chest will be there, and wide set nipples will be there. The prominent occiput is very important finding. The rocker bottom feet or sometimes even club foot can be seen in these kids. Then the overlapping digits in fingers and toes, there can be overlapping. That is a very typical feature of Edward syndrome baby. So Edward syndrome is a uh, condition with a very bad prognosis. Mostly these kids will not survive because they will have respiratory problems, cardiac issues, and it will be very difficult to wean them off respiratory support, and they will have difficulty feeding as well. They will not be able to swallow mostly, and so very bad prognosis for this condition. But we have seen kids surviving up to 2-3 years sometimes. So all these kids should undergo the echocardiography also, because Edwards can be associated with cardiac abnormalities. Then Patau syndrome is trisomy 13. This is another very common genetic condition, uh, and it is typically associated with midline defects. That is, cleft palate and cleft lip can be there, and also this condition. The eyes are very close together. The gap between the eyes is very low in this condition, and sometimes there can be fused eyes, both eyes fusing into one eye, which is called a cyclops eye, can also be seen. That is very rare. Cyclops eye is very rare, but the gap between the eyes will be very low usually, and this is also associated with that. The fusion of the eyes is also associated with fusion of the brain inside, fusion of the cerebral hemispheres, which is called holoprosencephaly, and there will be a single ventricle instead of two ventricles in both hemispheres. A single ventricle, so holoprosencephaly can be there. Cardiac malformations are very common, like septal defects, very common in trisomy 30. It is always associated with all midline defect conditions. Cutis aplasia is another very common finding in Patau syndrome. So these are the features. Um, the prominent findings are cleft lip and palate. Then I think other than that, I think the cleft lip palate will be the all the other features are explained in other syndromes also. Typically, the cleft lip palate is a uh, which is that is characteristic for Patau syndrome. And also, if the eyes gap between the eyes is small, then you should screen for a USG cranium and see whether holoprosencephaly is there, or even partially fused cerebral hemispheres also suggestive of Patau syndrome. Now, among the genetic conditions, congenital hypothyroidism is a very, very, very important condition. And in any newborn screening, congenital hypothyroidism shouldn't be ignored. It should be part of all newborn screening. And so congenital hypothyroidism is a very common condition now, because maybe it is being detected because of the widely available screening programs. The frequency is around 1 in 3,000 births, and FT4 and TSH should be done in all newborns, because only both, usually TSH only is done, like previously we were doing only TSH, but it is better to do FT4 also, because sometimes primary hypothyroidism can be missed if both are not done. And sometimes in some cases, initial TSH surge will be there in newborn, and the TSH is high in newborn, and because of that, free T4 also can be high in newborn. So in that case, we should be retesting again at around 10 days of age. So the causes for hypothyroidism, the common causes developmental defects of the thyroid gland, agenesis, or sometimes ectopic thyroid. These are very common conditions which are seen. And another very common condition is dyshomogenesis. Dyshomogenesis is synthesis. The hormone synthesis defects can be there in hormone synthesis, like a peroxidase enzyme defect, which can be associated with deafness also. So, uh, in any thyroid, like any baby who is undergoing T4 TSH screening, and we find the TSH is high, then if the free, even if the free T4 is normal for the baby or a little higher side for the baby, then we can wait little more, like we can wait till around 10 days and then repeat the test again. But if the free T4 is found to be low, then we shouldn't be waiting very long, because already the baby's brain can be affected with a low free T4. So if free T4 is low, then we should be screening. We should be repeating the test as soon as possible, and also start the baby on medicines as soon as possible, because if the medicine is started as soon as possible before the free T4 goes low, then the baby's IQ will not be affected at all. This is completely 100% treatable condition, and all the kids who are having hypothyroidism should have USG thyroid, and if possible thyroid isotope studies also, because we can clinch the diagnosis better with USG thyroid, can pick up all the ectopic thyroid conditions and the agenesis and all that. But thyroid isotope studies will be able to correctly tell you about the function of the thyroid gland. So in that case, we'll be able to counsel the parents better regarding the how much dose should be given. Like if it is an agenesis, anyway, we should be giving the complete dose till this is lifelong treatment for the baby. But if in case it is in dyshomogenesis also, it is like that. It should be continued, and at around 3 years we can check the value once again. Till 3 years it shouldn't be continued without any stop at all. At 3 years for dyshomogenesis, sometimes it can recover, sometimes enzymes can develop. So then we can stop for some time, and maybe around 2 weeks stopping of treatment and doing the test once again to see whether it is still TSH is still abnormal. Then we can continue it lifelong. Yeah, this another thing is like maternal thyroid disorders like Graves' disease or Hashimoto's thyroiditis, which is associated with antibodies, thyroid antibodies, receptor antibodies. If they are there, they can enter through the placenta, they can enter the fetus, and sometimes these antibodies can persist in the baby till around 3 months of age. So in those conditions also, we should be screening the baby once again. Even if the neonatal screening is normal, we should be screening the baby once again at around 3 months of age. Also, if the mother was on anti-thyroid drugs, then also we should be screening the baby once again. Now, that is about the genetic conditions. So, shall we go into the next part of the topic, that is around metabolic disorders? We'll be talking about. So, what are the symptoms of a metabolic disorder? The baby will be, usually it is a sepsis-like presentation. So, what are the features of sepsis? Infection in the baby. What will be the typical presenting features? PGs. So it is all visible. Poor feeding, failure to thrive, poor activity for the baby, recurrent vomiting can be there, and all these can lead to dehydration and ketonuria. And most of the time, metabolic conditions will be manifesting after starting of foods or after a change in diet, like in fructose intolerance. The symptoms will be starting only after weaning is started, because otherwise there is no fructose in the diet. Once weaning is started, it will manifest. So mostly after starting of feeds, but some conditions can present even before that, like mitochondrial disorders can present even before that, because some defects of metabolism will be like constantly happening in the body, so they can present antenatally also. So unexplained neurological symptoms and sepsis-like presentation with no sepsis. When you test for sepsis, you find the CRP is negative. The blood counts are normal for the baby. Blood counts will be mostly abnormal for even these kind of symptoms, because this baby is under stress, and there will be the high count will be there for the baby. Sometimes low counts can also be there for some of the metabolic syndromes. So, but CRP will be mostly negative for these babies. So, sepsis presentation with negative CRP and negative blood culture, then we should suspect a metabolic syndrome. Then other findings, collaborative findings, will be jaundice, hepatosplenomegaly, and bleeding manifestations, which can also be there in any infection. Any sepsis, any systemic sepsis in the baby can cause jaundice, hepatosplenomegaly, and bleeding manifestations. So all these conditions, when sepsis is negative, when you find no infection is there, then you should be thinking about a metabolic disorder. So here also consanguinity, in the history, consanguinity is very important. Like we said in the genetic problems, neonatal deaths, seizures in the family, mental retardation in the family, another metabolic disorder in the family, or late infant deaths, or like toddler age group children who were abnormal in the family. That history is very important. Then maternal health syndrome can be associated with HELP syndrome is associated with preeclampsia conditions. Uh, Low platelets can be there, elevated liver enzymes can be there, and hemolysis can be there in HELP syndrome. So this condition is associated with long chain 3-hydroxyl acyl coenzyme dehydrogenase deficiency, which is a fatty acid disorder in the fetus. So these are the things which are important in the history. Then in investigations, as we told, this baby is presenting like an infection, sepsis. So we should do a sepsis screen. So sepsis screen means initially we'll be doing blood counts and CRP. If the CRP is negative, uh, and like if the blood counts are suggestive and the CRP is positive, then we'll be going in for the blood culture also. If the CRP is negative, then we should be thinking about whether this baby is having any metabolic disorder. Usually blood gas is also done along with the sepsis screen, because sepsis babies also can have lactic acidosis, they can have low bicarbs. So ABG also will be done along with the sepsis screen. ABG can tell us a lot of things, whether the baby in sepsis babies, sometimes respiratory distress can be associated, because sepsis can be associated with pneumonia. Sepsis, if associated with pneumonia, it can cause the carbon dioxide to be high. If it is not associated with pneumonia also, it can be associated with acidosis, which can cause tachypnea. The breathing rate will be high for the baby, then the carbon dioxide can be low for the baby. There will be metabolic acidosis and respiratory alkalosis in such conditions. So ABG is very important in sepsis also. So it is always part of sepsis screen. If ABG is done, then if CRP is negative and the ABG is showing acidosis, then your metabolic condition is more likely there. Then blood sugar also will be tested, because blood sugar also can tell us a lot of things. In sepsis, hypoglycemia can be there, hyperglycemia also can be there. Hypoglycemia can be there in various metabolic conditions like galactosemia. So here also, like all collaborative findings, sepsis screen negative, blood sugar is low with acidosis, lactic acidosis, then we should think about specific metabolic conditions. Serum ammonia and lactate are the most important screening parameters for a metabolic condition. So ammonia lactate should be tested as soon as you suspect a metabolic disorder. Ammonia can be high in urea cycle disorders, and sometimes just pick where just a baby with recurrent seizures also can have high ammonia. In sick babies, ammonia can be high. In extreme preterms, ammonia can be high. So just because the serum ammonia is high, you cannot immediately suspect a metabolic disorder, but it is one of the collaborative findings, serum ammonia being high. And in urea cycle disorders, it is very, very high. Usually, if you get an ammonia value which is more than 500, 700, then immediately you should think about urea cycle disorders. Then serum lactate and pyruvate, the ratio of the lactate and pyruvate is also important because it can help in clinching the diagnosis. Whether it is a Krebs cycle disorder, those diagnosis can be made with a lactate pyruvate ratio. If acidosis is there, we should be checking the lactate and the pyruvate separately. In these, even for ammonia, lactate, pyruvate, arterial sample is better because arterial sample is a free flowing sample. If you take a venous sample which is squeezed, then the lactate can be high in that. Despite baby has no acidosis, but even then lactate can be high in that squeezed sample. So it is better to take an arterial sample in such conditions. And the transport to lab is also very important. It should be transported to the lab as soon as possible because otherwise the values can be deranged also. Then urine testing is also important. Reducing substances in the urine is positive for galactosemia, ketones in urine, ferric chloride test, DNPH test for various amino acid disorders. Then RFT and LFT also important because various metabolic disorders can cause derangements in renal function test and liver function test. And also USG abdomen because USG abdomen various metabolic conditions can cause hepatosplenomegaly. Now, further investigations like higher investigations like chromatography, mass spectrometry, high performance liquid chromatography, all these are done if from the prior investigations you think there is a high possibility of metabolic disorder, then we should go in for all these special investigations. In just from the counts itself, as I told you, in the blood counts itself, if neutropenia is there, if thrombocytopenia is there, they can be there in metabolic conditions like propionic acidemia and methylmalonic acidemia. So counts are also important. Just from the blood counts itself, we get a clue to these conditions. Also, like in when we like in genetic conditions like Dye-George syndrome, lymphopenia can be there. So counts are very important in such conditions. Low serum uric acid is seen in molybdenum cofactor deficiency. That is a specific finding. Like that, low serum cholesterol is seen in Smith-Opitz syndrome. These are all specific findings in such syndromes. And CSF glycine, a baby presenting with seizures, and you there is non-ketotic. It is non-ketotic condition, but you test the blood and the CSF glycine is high. That is non-ketotic hyperglycemia. This is resistant seizures which will not respond to any management. Then in such conditions, from all these investigations, if you get a clue to the condition, then MRI brain is also important because it gives clues to the diagnosis like in Selvager syndrome, Menkes syndrome, non-ketotic hyperglycemia, a specific MRI brain finding will be there in such conditions. And if the baby, like as we said in the genetic diseases, if the baby doesn't survive, postmortem samples of blood, urine, skin and liver should be taken because it will help the next baby of the parents. It will be helpful for the next pregnancy. Now, diagnosis of a metabolic condition is a very difficult thing because you get so many findings. You have to corroborate these findings and come to a diagnosis. So, if acidosis is there or acidosis is not there, that is a clue. So, without acidosis, if acute encephalopathy is there, you should think about pyridoxine dependency, non-ketotic hyperglycemia, glycogen storage diseases, hereditary fructose intolerance, maple syrup urine disease, organic acidemias, and urea cycle defects. So, these are all acute encephalopathy, but without acidosis. If with acidosis, then you should think about organic acidemias and congenital lactic acidosis. If lactic acidosis is there, elevated lactate pyruvate ratio, lactate and pyruvate should be measured. And if there is an elevated ratio, it is suggestive of pyruvate dehydrogenase and pyruvate decarboxylase deficiency. So these kind of things, like from the all the investigations and the baby's presentation, the ABG findings, you can think about certain suggestive conditions and then go for the testing, because all these metabolic conditions, around 119 conditions will be tested in certain packages are there for these metabolic conditions. In some conditions 6 will be tested, in some tests 6 conditions will be tested, some 119 conditions will be tested. So you can send blood and urine for these conditions. It will be very confusing if you test for all. The tandem mass spectrometry is done for a variety of conditions. So it will be better if you get a clue from the baby, from all the imaging findings, baby's presentation, along with the imaging findings. If you get a clue, it is better for clinching the diagnosis. So, hypoglycemia and ketosis, it indicates abnormalities of gluconeogenesis pathway. Like fasting, when the baby is in fasting, gluconeogenesis pathway will manifest at that point of time. Whenever we are fasting, gluconeogenesis pathway is activated. So, if during fasting, if there is hypoglycemia and elevated lactate, then it indicates glucose 6 phosphatase deficiency. Also in hereditary fructose intolerance also you get a similar finding, but it doesn't manifest in newborn period. If it is after carbohydrate loading, like after feeding, if it is manifesting, hypoglycemia is manifesting after feeding, then it is suggestive of galactosemia, where the baby is not able to metabolize the galactose. And this can also cause lactic acidosis. So glycogen storage conditions are also similar. After carbohydrate loading, the manifestation happens. Now, ketosis with hypoglycemia. Ketoacidosis with hypoglycemia happens in organic acidemias. So, from the investigations, we'll be able to clinch the diagnosis in organic acidemias, and acidosis without ketonuria is seen in fatty acid oxidation defects. So, these are the clues to the diagnosis in metabolic conditions. It is not at all easy. It is very confusing also. So we have to corroborate the findings, and also hypoglycemia with hepatic dysfunction, that is a typical finding in galactosemia. Nowadays in newborn screening, we screen the babies, all the babies born in the hospital for congenital hypothyroidism and also 6 metabolic conditions. CH is also included. Congenital adrenal hyperplasia is also included in these conditions. Phenylketonuria is there. Galactosemia is there. Cystic fibrosis is there. So these conditions are typically screened for all babies. So if the screening test is positive, they tell us by around 3 days. If the screening test is positive. If it is negative, we inform the parents within around 2 weeks. So that is done for all the babies born in the hospital. Now, hypoglycemia, as I told you, with hepatic dysfunction is seen in galactosemia and fructose intolerance. With hypoketosis, hypoglycemia with hypoketosis, as I told you, it is seen in fatty acid oxidation. Fatty acid oxidation defects will not have any ketosis. Hyperammonemia, typically in urea cycle disorders, as well as organic acidopathies. And transient hyperammonemia of newborn is also seen. Sometimes a baby presenting with poor activity, you test for the ammonia, it is high. Just fold up the baby, sometimes the baby can become all right, because there is a condition called transient hyperammonemia of newborn. If the ammonia repeated values, when you test serial values of ammonia is increasing, then it is more suggestive of a urea cycle disorder. Otherwise, if it is decreasing values, it is more suggestive of transient hyperammonemia of newborn. Hepatomegaly, just while examining if hepatomegaly is there, it is suggestive of GSD, glycogen storage disorder, alpha-1 antitrypsin deficiency, and Selvager syndrome. Selvager syndrome, the facies will be almost like a Down's baby, and there will be like a patella, in the patella there will be stippled calcification. That is a clinching point for the Selvager syndrome. There will be hypotonia, facies almost like flat facies for the baby, and there will be brain findings also for Selvager. It is a peroxisomal disorder, another metabolic disorder which can manifest at birth itself. Hepatic failure can be there later for galactosemia and hereditary fructose intolerance, also tyrosinemia. Hypotonia is seen in Selvager syndrome and non-ketotic hyperglycemia. And mitochondrial myopathies also can have acidosis, lactic acidosis, along with muscle weakness. Hypotonic baby with lactic acidosis is suggestive of mitochondrial myopathy, which is like maternally inherited. There will be history in the mother's family in such cases, unless it is a new mutation. Muscle carnitine deficiency, GSD, all can have hypotonia. Muscle carnitine is also affecting the muscles, and GSD, glycogen storage disorder, there are various types, and the muscle glycorylase disorder can be associated with hypotonia. Then abnormal odor of urine, sweat, sweaty feet is seen in organic acidemia. Burnt sugar smell happens in maple syrup urine. Musty odor in phenylketonuria, rotten fish smell in tyrosinemia, cat urine in multiple carboxylase deficiency. So that is a list of things. So you should smell the urine of the baby also in such conditions. Now, dysmorphic facies, as I told you in Selvager, there is dysmorphic facies. Also, dysmorphic facies is seen in pyruvate dehydrogenase and glutaric aciduria. And cardiac problems can be there in Pompe's disease. Cardiomyopathy is seen in Pompe's disease. Conduction defects are seen in long chain fatty acid oxidation defects. Then non-immune hydrops, when the baby presents itself, when the baby is born itself, or in the fetus itself, you can have hydrops, edematous fetus, seen in lysosomal storage disorders like Gaucher's disease, Niemann-Pick, and gangliosidosis. So, how to manage these conditions? As soon as the baby comes, you're suspecting from these kind of the initial investigations. Take samples, urine and blood for the necessary investigation, and after taking samples, the oral feeds should be discontinued because it will add further insults, further toxic metabolite formation. So discontinue the oral feeds, and mostly these babies will have acidosis. If there is acidosis, give respiratory support to the baby, control the ventilation of the baby. Depending on the baby's blood gas parameters, we can decide which respiratory support to offer to the baby. And mostly these babies will be having poor feeding, they'll be vomiting. So correct dehydration, and the most important thing is maintain the hemodynamic stability for the baby. So taking care of the breathing and taking care of the hemodynamics is most important for any condition, any newborn condition. And hence for metabolic also, that is the most important thing, taking care of the respiratory part and the hemodynamics. Then so mostly we'll insert an arterial line for these babies because uh, otherwise non-invasive BP monitoring is not feasible in newborn sometimes. It can have variations. So arterial BP monitoring is very important for such babies, and you can titrate the inotropes depending on the arterial BP monitoring. And correct hypoglycemia, electrolyte abnormalities are mostly associated with such metabolic conditions. So sodium, bicarb, chloride, mostly all these electrolytes will be available in the ABGs also. So serial ABG monitoring is very important for these babies to correct electrolyte abnormalities also. And acidosis also should be monitored. Acidosis should be corrected. Some degree of acidosis is okay because acidosis generally shifts the oxygen dissociation curve, and better oxygen will be available to the tissues. But severe acidosis should be corrected because all the metabolism will be deranged in case of acidosis. Correct coagulopathies also, and treat seizures if it is there, like in non-ketotic hyperglycemia, seizures are there. Sometimes seizures are very difficult to treat. Sometimes you'll have to give a continuous infusion of midazolam to control the seizures along with other anticonvulsants. Then toxic metabolite formation, if lot of toxins are there, it is very difficult to treat, bring the baby back to normal hemodynamics. In such condition, we should go in for exchange transfusion or dialysis to remove the toxic metabolites from the blood as soon as possible, because if it is continued to remain in the blood, it can cause further insults to the organs like brain, or cardiac problems can happen. Then once after a certain point of time, it will be very difficult to revive the baby. So in such conditions, if severe resistant acidosis is there, we should go in for a dialysis or a exchange transfusion. Now, long-term management of these babies, uh, without the offending agent, like if it is a phenylketonuria, without phenylalanine reduce the, if it is not possible to remove phenylalanine completely because it is an essential amino acid. So low phenylalanine formula will be the best option in such situations. So nutrients without the offending agent, like in galactosemia, lactose diet is not possible for such babies. So lactose-free formulas should be given to a baby with galactosemia. Now, cofactor supplementation is very important because most of the metabolic disorders are due to enzyme abnormalities, and thiamine, pyridoxine, B12, biotin, riboflavin, carnitine, coenzyme Q, folinic acid, all these are cofactors for these enzymes. So once if there is a partial deficiency of the enzyme, then cofactor supplementation sometimes will be very helpful. It will correct the metabolic disorder to a certain extent. So, because all these are vitamins, a cocktail of these vitamins is generally given even before the correct diagnosis is available. It wouldn't harm the baby, and sometimes it will help the baby if any of these, cofactor, that enzyme, that corresponding enzyme is defective, then this will help. Metabolic manipulation, like as we told, some of the metabolic conditions further, that is the toxins are formed, the substrate which is formed because of the block in the enzyme, this substrate will get converted into other toxic metabolites. So metabolic manipulation to prevent this enzyme converting the toxin, converting the substrate to other toxic metabolites will help. So metabolic manipulation, that is called, which will be helpful in certain conditions. So now we'll go into some very important metabolic conditions, very common metabolic conditions like galactosemia, which presents in newborn sometimes with just jaundice. Jaundice is a very common symptom in newborn, and along with that, along with jaundice, if the baby is having vomiting, if the baby is having hypoglycemia, and you palpate the abdomen, you find a liver which is big, then you should suspect galactosemia for the baby, and it typically starts after milk feeding. The urine reducing substance will be positive, and the treatment is total lactose elimination from the diet, uh, and calcium supplementation, because we are eliminating milk diet, so calcium should be supplemented, and these babies are typically highly prone to gram-negative sepsis. Now, about hereditary fructose intolerance, it usually manifests later, not in the newborn period. It starts after introduction of fructose and sucrose in the diet. And unexplained vomiting after starting of weaning, hepatomegaly later, jaundice, seizures, all these are the manifestations. Urine reducing substance is positive, but the specific glucose test will be negative. Because it is fructose, the specific glucose test will be negative for such babies. Fructose avoidance is the management. Phenylketonuria, as we mentioned earlier, musty odor in the urine, unexplained vomiting. Rarely seizures can be there. High serum phenylalanine is the clinching point, and restricting phenylalanine cannot be eliminated as it is an essential amino acid. Tyrosinemia is similar to uh, phenylalanine, the same pathway in metabolism, present soon after neonatal period as acute liver disease. Phenylalanine and tyrosine restriction is important in such babies, and there is a metabolite called, this is a competitive inhibitor of the enzyme and prevents the toxic metabolite formation. It is called nitisinol. This is a drug which is used to manage tyrosine. Now, hyperammonemia syndromes, lot of metabolic conditions can this, because that is why ammonia and lactate are the first investigations which are sent whenever metabolic condition is suspected for a baby. So, hyperammonemia syndromes, in any hyperammonemia syndrome, stop protein intake. When the baby is acutely symptomatic, you have to stop the protein intake, because if the ammonia is very high, it can depress the brain further and it can lead to further brain insult. So, restrict protein intake, and after symptoms improve, you can start proteins, but a very restricted intake can be given, and a high calorie diet is very important for conditions like urocycle disorder. The nitrogen load, that is the bacteria in the bowel, can lead to more nitrogen production. So hence bowel sterilization to avoid nitrogen load is very important in such babies. And sodium benzoate is a metabolite which is used to activate alternate pathways. Arginine supplementation is also done in hyperammonemia. Organic acidemia is another condition with hyperammonemia. There will be acidosis also. So urea cycle disorder without acidosis and organic acidemia is hyperammonemia with acidosis. Control of acidosis is very important. High dose vitamin therapy is important in such conditions. Maple syrup urine disease, there will be enzyme deficiency of branch chain keto acid dehydrogenase. So there is a fair chance of neurologically intact survival if dietary restrictions are started early in life. In most of these conditions, this applies. If dietary restrictions are given early in life, they will have a near normal intellectual development. Isovaleric acidemia also, low protein diet. And methylmalonic acidemia, chance of, if it is vitamin B2 responsive type, then there is a neurologically better prognosis in, uh, in that kind of specific disorder. Now, in any metabolic or genetic condition, parental counseling is the most important part of management because any genetic or metabolic condition is a major emotional, social, and financial. This totally affects the family. It has a major impact on all these aspects for them. So we should be very carefully dealing with such conditions. We should have a detailed counseling of the parents, and the diagnosis should be made as soon as possible because maintaining they are in an unknown area, and the parents will be very worried what is happening. So once the suspicion is there, as soon as possible the test should be done. If it is a chromosomal analysis, it should be done as soon as possible, and we should be prompting the lab for you know an early report and counseling them as soon as possible. And so the diagnostic test should be done, and multidisciplinary meeting with all the people who are involved in managing the baby. That will help the parents in lot of ways. Usually we'll have a meeting which is video recorded so that all the physicians can be there. If physiotherapy people are there, uh, the ENT consultation may be there for ophthalmology evaluation can be there. So all the physicians can be present during the counseling so that the parents can ask the doubts regarding various systems, and they can refer to the video if any further doubts are there. So a comprehensive plan of managing the baby should be given to the parents once a diagnosis is made about whether it is a genetic or metabolic condition. This should be the plan of management, and the diagnosis should be discussed in detail. The further plan, how we are going to manage the baby, and the prognosis for the baby, also for the implication for them in further pregnancies. This should be discussed in detail with the parents. Now, in any field, I think this applies. We should learn and unlearn. Most of the lot of things which I have learned during my PG days have been proven wrong. So we have to unlearn that and keep on learning. And whenever possible, we should try to prevent a disease. If not possible to prevent, then at least we should try to cure the disease. If not possible, if cure is also not possible, we should give the maximum possible care to the baby, like palliative care to minimize the pain, uh, provide maximum well-being, whatever the condition is. Thank you so much. So we shall continue the discussion.
Yes, ma'am.
Yeah, yes, please.
Thank you so much, ma'am, for that enlightening and informative session on newborn screening. Your insights have truly enhanced our understanding of this vital topic. Now we move on to the Q&A session, where all the delegates get the opportunity to engage directly with Dr. Rajesree, ma'am, and ask any questions or seek clarification on the points discussed during the session. So, delegates, if you have any question, please feel free to type it in the chat box or use the hand raise option to ask directly. Ma'am, we have a question. What are the implications of fetal heart calcification if identified in a fetal echocardiogram?
Yes, that is a very commonly seen finding in antenatal ultrasound. Because the antenatal ultrasound is done so many times in babies, we see this echogenic focus in heart as well as in intestines very often. So, if there are no other associated findings in the baby, we generally don't do any further screening unless there is any examination. During examination, mostly we'll be visiting the babies on the first 3 days postnatal. As soon as the baby is born, we'll be seeing the baby, the detailed head to foot examination, including the cardiac examination. If the day 1, day 2 examinations are showing any other findings, then we'll go for the screening of the heart. Otherwise, if just a calcification, it is not indicated.
Okay, ma'am. We have another question. Any maternal blood biomarker or gut microbiome screening or advanced imaging technique of fetal brain has been identified to find out the likelihood of getting neurodevelopmental disorders like autism, ADHD, etc.?
Maternal
blood biomarker or gut microbiome screening
Okay. Maternal
or advanced
phenylalanine
imaging
levels.
techniques if it is.
Phenylalanine levels are associated with problems in the baby. Like sometimes mental retardation can be there, microcephaly can be there, autism manifestations can be there. Other than that, I'm not aware of any other. There will be, autism and ADHD is another specific area. There will be sometimes. I'm not aware of that. Maternal phenylalanine levels are very important in these kind of conditions.
Thank you, ma'am. I hope that question is cleared. Ma'am, we have another question. In case of maple syrup urine disease, since they be on a milk-based diet, what kind of dietary considerations should we advise?
Yeah, they have specific formulas available. It is not available in India that commonly, but they can be imported in such kind of most of the amino acid related branch chain amino acid disorders and all that. Specific formulas are available with those amino acids will be low in them. If they are like essential amino acids, they'll be restricted. Not absent, they'll be restricted in those formulas. So such formulas are available which can be continued, and they'll be so that there will be minimum insult, further insult to the baby's brain.
Okay, ma'am. Thank you.
These can be
Any
imported.
other?
There are some in hyperinsulinemia states for the babies. Sometimes hyperinsulinemia causing high insulin production in some babies, nesidioblastosis kind of conditions where insulin is high. You have to give a high glucose formula, high carbohydrate formula for such babies. So in such conditions, we generally import those formulas. It is not that commonly available in India. So whenever a specific metabolic condition is there, there are pathways like you have contacts with these kind of personnel who distribute these kind of specific products. So you can contact them and they will be providing that specific product.
Thank you, ma'am. Any other queries, delegates?
It was an exhaustive session, and I think very metabolic conditions are very confusing also. Whenever a baby comes, we have to read further. Most of the conditions we'll have to search further and read further and then come to a diagnosis, because metabolic conditions are so vast a topic.
Ma'am, we have another question from Dr. Arati Mohan. With such restricted and specific diets in such metabolic disorders, how well can babies with metabolic disorders survive?
Yes, as I told you, like low phenylalanine formulas, we generally give, we have one baby here under follow-up and one baby in the previous hospital where I was working. So they are, I wouldn't say the babies are completely normal, but after starting the diet, there are various studies with this, on babies on such diets. There are various studies also. So otherwise, phenylketonuria, there will be severe mental retardation. So once these formulas are given, they will have a near normal development. And survival is very good with these special kind of formulas. In one condition, chylosositis was there in a baby with, so in that baby also we were giving a specific formula, which was also imported like that. The other high carbohydrate formula is called Maxijule. So these kind of specific formulas are, as I told you, they have to be like, because it's not commonly used, they'll not be very commonly available also.
Okay, ma'am. Any other queries? We can wind up the session if there are no further queries. Yes, ma'am.
So I think
Ma'am, thank you once again for such a refreshing session.
Thank you, Rajya.
It was very.
Thank you.
Thank you, ma'am.
Thank
you to all the
for
delegates for your patient listening.
Thank you, Lakshmi.
Go ahead, ma'am.
Yes. Thank you. Bye.
Thank you, everyone, for your patient listening and the wonderful questions. With that, we come to the end of day 2 of our webinar, Srishti, on genetics and embryology. Hope to see all of you once again tomorrow. So please make sure to join on time so that you get your seat reserved for this webinar tomorrow. Thank you. Good day.